Now that I heard two bells from the church on Church Circle, I think we'll get started. They're a few seconds behind the computer's clock, but I'll go with that. Good afternoon, everyone. Thank you for joining us on this first virtual quarterly meeting of the Interagency Heroin and Opioid Coordinating Council for 2021. We'll be talking about it in a few minutes, but I know everyone has probably seen the fatality data that was recently released by the Opioid Operational Command Center. And so that'll be first up, where Director Schuh will give more information in greater detail in just a few moments. We also have a presentation from Dr. Aliya Jones, the Deputy Secretary for Behavioral Health at the Department of Health, who will give a presentation on racial disparities and the Overdose Task Force, as well as Erin Russell, who is the Center Chief for the Center for Harm Reduction in the Maryland Department of Health. She's going to give a presentation on naloxone saturation, the naloxone saturation formula. And with that, I will just do a quick roll call round robin here. I see Dr. Jones, Superintendent Woodrow Jones from State Police. Are you present? Okay. Superintendent's not here. I know that Robert Green is not here today. Joseph Cleary here for Juvenile Services.
Yes, present, sir.
Okay. All right. Thank you. Is it Jay or Joseph or both?
You can call me either one.
Okay.
Perfectly fine.
Okay. No one on this line is old enough to remember there was some comedian who said you can call me this and you can call me that. So, okay. Dr. Delbridge from MIMS. We are also running.
Yes, sir, I'm here. Sorry, I was on.
Oh, Dr. Delbridge, good. Dr. Sammons, I know, is not available. Russ Strickland.
I am here. Thank you.
Okay. Director Barton from Problem Solving Courts.
Yes, sir. Gray Barton.
Thank you. And Director Schuh. I saw Director Schuh. There he is. Okay. And Glenn Fuston.
Good afternoon, sir.
Good afternoon. Okay. I don't know if everyone has had an opportunity to look at the minutes from the last meeting. I know it was several months ago. But if there are any changes or recommendations to change, let us know. And if you don't have any changes, we'll entertain a motion to approve those minutes. Do I have a motion then to approve?
So moved.
Okay. A second?
Second.
Okay. Is everyone in favor? Say aye or signify those who are on camera.
Aye.
Signify with
Aye.
Aye. Thank you. Okay. With that, I'm going to turn it over to Director Schuh for an update from the Opioid Operational Command Center on the fatality report.
Okay, thank you, Lieutenant Governor. Are you able to hear me?
Yes. Yes, quite well.
Great. I don't know whether I'm coming in over the phone or over the computer, so I will just continue to use the phone just in case I've been having difficulties. Good afternoon, everybody. As the Lieutenant Governor mentioned, the OOCC released the third quarter fatality report approximately a week ago, and I'd like to take this opportunity to walk you through some of our findings. If you could go to the next slide, please. And the slide after. Thank you. If you look at the far right, you'll see that there were 2,025 fatalities from all types of drugs and alcohol during the first 9 months of 2020. That was up a little more than 12% from the prior year figure of 1,806. This was obviously a great disappointment to us after the progress of 2019, when we saw a decline for the first time in more than a decade in the number of fatalities related to substance misuse here in Maryland. Fatalities went down from 2,406 in 2018 to 2,379, a 1.1% decline. Small, but important. Next slide. This breaks apart the first 9 months of the year 2020 as compared to the first 9 months of 2019. 2020 is on the right. On the bottom in dark blue is the first quarter. As you can see, the first quarter really was not much changed from the prior year, 621 to 626. But as COVID began to kick in, we began to see the after effects. In the second quarter in light blue, fatalities went from 594 to 700, a jump of 18%. And that continued through the third quarter ending September, 591 increasing to almost 700 in the third quarter. At this rate of increase, just extrapolating out, not predicting, but extrapolating out, we could approach 2,700 fatalities in the state of Maryland for all of the year 2020. This would be the worst year on record. Next slide. If you look at the far right, you'll see that within the larger category of substance use fatalities, 1,829 were related to opioids. That's about 90%. Opioids were up 14.5% from the same period in 2019, increasing from 1,598 to 1,829. That compares to about 12% for substance misuse in the aggregate. As a point of comparison, if you look back at 2015, the fatalities in that year were comprised 86% opioids. So we've seen a significant increase over the years in the overall fatalities that are resulting from and involve opioids. Next slide. Here we have the three major opioids that are at work here in the state of Maryland. On the left, fentanyl. Fentanyl was involved in 93% of all opioid-related fatalities, and therefore 84% of all substance use fatalities in the aggregate. Fatalities from fentanyl went from 1,458 last year to 1,702 this year, an increase of 17%. Excuse me. Heroin continues a trend that we've been watching here on this committee for now 2 to 3 years. Heroin was down 29% in terms of fatalities from 579 to 411. Very welcome news. This is the fourth year of declines for heroin. Unfortunately, we did see a reversal when it comes to prescription opioids on the far right, increasing by 12% to 320. This is especially concerning because we know from hard experience that many people enter the world of addiction, the dark world of addiction, through this door. Next slide, please. This breaks down the experience on a county by county basis. As you scan over this chart, you'll see that there were 5 counties that were down, which is great news. 1 was flat, but 18 were up. So 3/4 of Maryland's 24 counties experienced more fatalities during the first 9 months of 2020 than they did during the first 9 months of 2019. We saw especially sharp increases in Prince George's County, Cecil County, Allegheny, Howard, Charles, Worcester, Dorchester, and Somerset, all increasing more than 40%. We were very encouraged by the single-digit increases in Baltimore City and Baltimore County, and by declines in Frederick, Hartford, Carroll, Talbot, and Kent. Looking at things regionally in the next slide, you'll see that the Western Maryland region is lighting up in red. There was an increase in the region in fatalities of over 53%, an enormous increase in that period of time, followed by Eastern Shore and the Capital Region, both of which in pink increased by about 35%. On the good news side, in light blue, the Central Maryland region, we saw moderate increases, as I mentioned, in Baltimore City and Baltimore County, and actual declines in Hartford and Carroll, which made Central Maryland the least impacted region on this measure, based on the percentage increase in fatalities. Central Maryland was up 6.4%. Looking at the regions based on mortality rates, we see a little bit of a different story. Central Maryland suffers a reversal here, as we just discussed. Central Maryland was light blue, very moderately impacted by increases, yet remains the hardest hit region of the state from an overall mortality perspective. 56.1 fatalities per 100,000 population in the central region of the state. The West is lighting up red by this measure as well. As you recall, they were red in terms of rate of increase in fatalities during the first 3 quarters of this year, and they're red with respect to mortality. So they're getting it both ways. And I'll mention as an aside that the western part of the state has been among the hardest hit regions from COVID. So our dear friends and neighbors in Western Maryland are truly suffering. The DC metro region was a point of good news with respect to mortality. It has consistently been and still is the least hard hit region of the state from a mortality perspective. And this is a positive flip from the prior chart where, as you recall, the DC region was in light red. So what we're seeing is continued low levels of mortality because of a historically less intensive drug culture, at least with respect to opioids in that part of Maryland, but rather rapid rates of increase in opioid-related fatalities. Hopefully, we won't see the DC metro region, the capital region, catching up to the rest of the state. Looking at non-opioids, there are a number of non-opioids involved in these fatalities. Cocaine is the largest actor in the non-opioid class. 688 fatalities involved cocaine. That's 34% of all intoxication-related deaths. Cocaine-related deaths were up almost 6% over the period. Alcohol, up 37%, 431 fatalities involving alcohol during the first 9 months of 1990. Benzodiazepines were up slightly, PCP up slightly, and methamphetamine up 79%. Small numbers going from 29 to 52, but an alarming rate of increase. Overall, when you take these compounds together as a group, 65% of all substance use related fatalities involved a non-opioid. So as we said earlier, opioids are involved 90% of the time, but non-opioids are also involved 65% of the time, which points to the common practice of using multiple substances, polysubstance use. Next slide. We've seen other dislocations in the system as evidenced by emergency department visits, for example. On this slide, you'll see that emergency department visits were down 17.7% during the first 9 months of the year as compared to last year. And this is despite the significant increases in overdose fatalities during that same period. We also saw disruption in naloxone administrations by emergency medical personnel. If you look at the first quarter of the year on the left, you'll see that 2020, which is in dark blue, was tracking significantly below 2019. That began to change during the second quarter. And as you got out to about week 23, you'll see that 2020, again in dark blue, caught up to 2019 and surpassed it and has stayed above 2019 for almost the entirety of the third quarter. Next slide. We have begun looking more intensively at various demographics that are at play with respect to the opioid crisis, looking at race. The fatalities related to white Marylanders went up from 1,012 to 1,163. That's a 15% increase. Our African-American community experienced 766 fatalities, up 8.5% from 2019, where there were 706. The Hispanic community up 57 to 72. And with respect to the rates of increase for white Marylanders versus black Marylanders, what we experienced in the first 9 months of the year is a bit of a reversal, as you'll see in a second. For a couple of years now, the rate of increase among black Marylanders has been quite a bit above that of white Marylanders, and that has reversed so far in 2020. Fatalities among whites are growing significantly faster than among black Marylanders. In terms of gender, in the middle of the chart in purple, you'll see that 73% of all fatalities were male. So it's about a 3/4 to 1/4 split. That's been consistent over most of the pandemic, most of this epidemic. And with respect to age, if you toss out the under 25 group, you'll see that the impact of opioid related fatalities by age cohort is pretty even. This is not a disease of the young or a disease of the old or a disease of anybody. This can get anybody of any age. Next slide. This is what I was getting at a moment ago. If you look at the top line, that's white, non-Hispanic Maryland fatalities. Relatively slow rate of growth from 2011 to 2015, and things took off with fentanyl in the 2016-17 period. And then for white Marylanders, it began to tick down, and we saw a 10.8% decline from 2017 to 2019. In blue, we have in the middle there, black Marylanders, also increasing relatively slowly from 2015, but then very sharp increases from 2016, slightly up in 2017, and then further sharp increases in 2018 and 2019. And in fact, between 2017 and 2019, black Marylander fatalities were up 35% compared to down 11% for white Marylanders. Again, that trend reversed itself this year with, on an annualized basis, you'll see that white Marylanders are on a course for 1,551 fatalities this year, up about 15%, while African-American Marylanders are looking at a rate of increase closer to 8.5% to 1,021 for the year. Again, those are just extrapolations, not predictions. That's just the math of it. Next slide, please. Wanted to take a moment to give you a brief overview of some of the programmatic highlights that occurred over the past year here in Maryland. While the coronavirus pandemic has complicated the opioid and overdose crisis, we have been impressed with the agility of our state and local partners as they've pivoted to continue providing services to those at greatest needs. I'll quickly run down some of the highlights of what the state has accomplished over the past year, which I'll preface by saying this list is not exhaustive. This is just intended to give you a flavor. In terms of awareness and education campaigns, the Maryland Department of Health has continuously run a series of awareness and educational campaigns promoting how to use naloxone, the Good Samaritan Law, the Talk to Your Doctor campaign, and utilizing 211 Press 1. There are resources available to modify and support these campaigns in the coming year, which is great. PDMPs, provider insight reports. The PDMP has produced reports that will provide insight into prescriber practices through provider insight reports available on CRISP. These reports will display aggregate data based on a provider's prescribing history and will allow the provider to compare his or her prescribing practices to those of peers based on a common set of metrics. Department of Aging's distribution of Deterra pouches. The Department of Aging distributed nearly 5,000 Deterra pouches for distribution at local senior centers, which will help individuals discard unused medications in the home. Expansion of Handle with Care. The Handle with Care program, as many of you know, notifies local school systems if there has been a public safety involved event with a child present. This has been expanded to 765 schools in 16 counties in the state. It is a wonderful program. There are a couple pending applications, expansion of law enforcement assisted diversion or LEAD. The Governor's Office of Crime Prevention, Youth and Victim Services and the Department of Health have continued to collaborate to provide technical assistance to support public safety and public health partnerships. In addition to the 4 operating LEAD programs in the state hopes to bring an additional 5 sites online in 2021, which is great news. Regrounding our response. The program includes raising awareness and educating people on 5 public health principles for responding to the opioid and substance use crisis. The modules are stages of change, adverse childhood experiences, social determinants of health, MAT as overdose prevention, and the drug user health framework. Although originally designed to be delivered in person, Regrounding Our Response pivoted to a virtual platform because of COVID and has reached hundreds of individuals in all 24 jurisdictions. Although this list was once again not exhaustive of the work that was done, it serves as a highlight of some of the important efforts that have continued to be implemented during this unprecedented year. Next slide, please. The OCC is currently wrapping up our 2021 interagency opioid coordination plan. This is the annual strategic plan required under the governor's order. The coordination plan identifies the state's goals for responding to the opioid crisis and compiles the state's highest priority projects for the coming year. Some of the priorities that we expect to include in the plan are enhancing state infrastructure to respond to adverse childhood experiences or ACEs, establishing a comprehensive crisis response system. This has been a consistent theme of this committee, as everyone knows, utilizing data to inform programmatic decisions, recovery residence expansion. This has been an issue across the state. There are parts of Maryland that have no recovery residences, no sober homes whatsoever. Improving care coordination. And finally, wraparound services for individuals who are justice involved. So that concludes my report, Lieutenant Governor. We are readily reachable at help.oocc@maryland.gov. Back to you. Thank you.
Thank you, Director Schuh. 2 questions that I have, and then 1 comment. The decline in heroin as the main culprit of overdose fatalities, and we've seen that for a number of months, well, a number of years. Is that really linked to the fact that fentanyl is probably squeezing out heroin in terms of an ingredient that people who were buying heroin, the very few, if you go out on the street to buy heroin, you're most likely to get fentanyl than you are to get heroin, or at least it has more fentanyl in it than it does heroin, and probably more fentanyl and cocaine in it than it does fentanyl and heroin, or just heroin. That fentanyl is basically squeezing heroin even out of the market.
I think your analysis is exactly correct. Heroin is being elbowed aside by fentanyl for a number of reasons. As a synthetic, fentanyl is relatively easy to make from readily accessible precursor chemicals. It is very compact and easy to hide. Because of its compact nature, it is very powerful by quantity. It's 50 times to 100 times more powerful than heroin at a comparable quantity. Heroin, on the other hand, is a natural product. It has to be grown agriculturally. It has to be harvested. It has to be processed. It has to be then packaged, transported great distances, either from South America or from Asia to the United States, with all the risks for the transporters and dealers involved in that supply chain. And finally, the margins are the profit margins in fentanyl, for all those foregoing reasons, are much higher than they are in heroin. And so as things have evolved, when fentanyl really first hit the scene, it's been around a long time in its prescription form, but when this street brew really took off in 2015, it was more of an additive. The dealers were adding it in to improve their profit margins on heroin and other products. But we're increasingly finding that fentanyl is a drug of preference for many people who use drugs, and that it is, as you said, it is pushing heroin gradually right out of the market, maybe completely.
And then the other on the emergency department decline for those who survive an overdose. Could that decline be partly due to COVID, that people are, were afraid to go to the emergency room, even though they were at death's door? But somebody is saying, I don't want to go to the emergency room, particularly if they could revive them with Naloxone. It's like, no, I'm not going there. Do you think, and maybe Dr. Jones or anyone else, I think Dr. Delbridge, if that's somewhat COVID related, that, we've had overdose fatalities up, but hospital visits, or at least emergency department, down.
I think that the COVID is probably the driver of that. Now, ED utilization was starting to go down in 2019 also, but it was much lower in 2020 than what one would have projected because likely of the COVID situation. And you remember, if someone's going to the ED because of an overdose, meaning someone has to be with them or see them overdosing, and with people social distancing, more people were likely using on their own. And so that's also who's going to call, anybody who, if someone's in a state of an overdose, you have fewer people making those phone calls and saving, which translates into more people overdosing and dying and not getting to the emergency room to get the care that they need. But ED utilization likely was down also just because people didn't want to go to didn't want to be out in public, period, because of concerns over COVID.
Okay. All right. Thank you. And Steve, I'm glad that you mentioned the priority being recovery housing. Yeah, that's been an issue that, a lot of jurisdictions aren't crazy about it, and the NIMBYs that, they want to see people recover. They just don't want to see them recover next door to them. Even though this is not, it's not a halfway house. It's not a methadone clinic. But that's part of the stigma. So, okay. Thank you. Dr. Jones, I believe you have I don't know if there were any other questions. I'm sorry with regard to Steve and his presentation.
Sir, this is Glenn Fusen. If you don't mind, I'd had a couple of questions. Steve, and I know that it's more of a comment because I know you're doing this already. Obviously, as we see those increases in that western area of Maryland and prior lives, I did a lot of work with Pennsylvania and West Virginia because they're so integrated. And if I understand correctly, that western area of Pennsylvania and West Virginia are also seeing that kind of increase. So if there's anything I can do to help with connections out there, I'm sure you already have them. Please let me know. I'll be more than happy to do that.
Wonderful.
From the law enforcement side, but also from the public health side of the house.
Absolutely. Thank you. Yes, we'll take you up on that.
The other thing I'd mention, just so that everybody's aware, Steve mentioned the work with the adverse childhood experiences, and our offices have been collaborating quite a bit on that since our office is focusing on these adverse childhood experiences from a global standpoint, from abuse, neglect, and other impacts that COVID are having on these children. It's certainly an impact from the opioid side of the house as well. So again, I just want to thank Steve for his partnership and his collaboration there.
All right, excellent. Thank you, Glenn. Are there any other questions for Director Schuh? Okay. Secretary Jones? You're muted.
Sure. Thank you. Thanks so much for the opportunity to present and talk about this new task force. And thank you, Lieutenant Governor, for approving the creation of a task force to address healthcare disparities as it pertains to overdose deaths in the state of Maryland. So as Steve has already shared, Maryland continues to experience high numbers of overdose-related fatalities. And he mentioned the increases in unintentional drug and alcohol-related intoxication deaths compared to in 2020 compared to 2019. Your administration has been invested in developing a comprehensive infrastructure to respond to the acceleration in overdose fatality deaths. And in 2019, we were fortunate in that we saw a decline in overdose fatalities for the first time in over a decade, actually. And though we did see this plateau in overdose deaths and a slight decline in overdose fatalities in 2019, as Steve has showed you, there were marked racial disparities that were observed between 2017 and 2019. And the narrative that's often told about the opioid epidemic since it was named an epidemic was that this was a problem, and that this problem had a different face, and that the face of addiction had changed, and that this was no longer about Black and brown people with drug problems, but rather white people who didn't traditionally and weren't expected to have such problems en masse. This was more of a relatable demographic, and it created, and the narrative became more of an empathetic way of managing drug addiction rather than the historical way that drug addictions were managed, which was one of punishment as opposed to treatment, and shifting the perception framing of this disease of an opioid, framing this from a moral failing or a character failing to a disease, and using a disease-based model and the way that we managed it, moving it from a criminal justice issue to a public health and a medical issue. So as a person who's always thought of substance use disorders as medical issues, at least since my early years in residency, I fully embrace this concept and this conversion in the way that we manage substance use disorders, particularly opioid use disorder, as it was framed because it was a healthier and more effective way to address substance use disorders in general, treating them as diseases, not as moral failings or as character flaws. And it wasn't lost on me as a provider of color that, and noticing that the demographics and changes in the demographics and where the deaths were occurring, that wasn't lost on me on the way that the disease concept and model was changed. But that doesn't change the fact that I was still moved by the number and the sheer number of people who were lost by this disease process, regardless of their ethnic background. So we find ourselves here in this place right now, fighting this disease with every resource that we have, with all of our ingenuity and all of our innovation. And we are beginning, or had at least been beginning, to see the impact of our efforts in the state of Maryland as it came to stabilizing opioid overdose deaths, and after many years of continued elevation with no end in sight. However, if we only looked at our numbers in aggregate, we would think that we were doing a great job, and we would be missing an unfortunate and very troubling truth. And that truth would be that everyone is not benefiting from all of the hard work that we've all been putting forward to combat the opioid epidemic. And in fact, the Black community in particular appears to have had no significant impact from all of our very, very diligent efforts. So we know, and Steve already showed you this graphic, we know that fentanyl is driving this increase in overdose deaths that we are seeing. However, the presence of fentanyl is having a disproportionate impact on African Americans, not only in the state of Maryland, but actually across the nation. And from 2011 to 2016, compared to all other racial demographics, Blacks or African Americans had the highest increase in overdose deaths due to, or the highest overdose death rate for opioid deaths involving fentanyl and fentanyl analogs. So solely dedicating additional resources to treatment, and we've been doing, I think, a phenomenal job with accessing and allocating more resources to treatment. Unfortunately, that has not been sufficient. And our treatment solutions, we have to ensure, are being tailored and targeted to address minority populations and communities if we're going to have the impact that we are all aiming to, that we're all striving for. As Steve has already shared, the increase in deaths for opioid-related overdose has been regardless of age, and the same thing is true for the African American community. However, it is noted that the highest number of deaths is seen between the ages of 50 to 59 years old, and that individuals who are over 60 and in the 30 to 39 age groups have seen quite phenomenal increases in the death rate from opioids. And this increase in deaths has skyrocketed in Black men, and it's also significantly impacted Black women as well. African American men are 3 times higher than Black women. Are dying at rates 3 times higher than Black women, and and so that rate is continuing to escalate. This is a pretty busy graphic. If you were to look at the top 3 lines, the blue lines correspond to the white population, the green lines in the middle correspond to the Black population, and the orange lines at the bottom correspond to other people who are designated as other, largely the Hispanic population. And so when you break the fentanyl as a cause of death down by race, the overall number of deaths caused by fentanyl are higher, of course, for people who are white. And the most recent period of 2019 to 2020, 60%, roughly 60% of all fentanyl overdose deaths were experienced by white individuals, while African Americans' cause of death by fentanyl was, we made up 39% of the population as opposed to 40% who were non-white, non-Black. However, the rate of change amongst individuals who are dying from fentanyl is significantly higher for the African American population than it is for the white population, where the rate of change of death has largely stayed steady. So from the same period of calendar year from 2017 to 2020, African Americans experienced a 33% rate of change in the number of overdose deaths caused by fentanyl. Those in the other category experienced a 16% change, whereas with white individuals, there was no significant change with respect to increase in the rate of death from fentanyl. This particular graphic talks a little bit about the populations for opioid use disorder and what that behavior looks like. So the prevalence of opioid use disorder is stable across ages and races. There is a disproportionate number or a higher percentage of Blacks who have opioid use disorders compared to our presence in the population. When you look at evidence-based treatments, which is what opioid treatment programs are, Blacks are underrepresented in evidence-based treatments until they're over the age of 50, and then they're overrepresented in treatment programs. And deaths of younger individuals tend to be in whites, while older individuals who die from opioid overdoses are grossly disproportionately African American. And if we were only looking at interventions and as a provider and a systems developer, if we're framing this disease as a disease of younger people, a younger demographic, and we're tailoring our interventions to that demographic, and we don't break things out by who's being impacted from a racial perspective or other demographic perspectives, you would overlook the fact that if you're creating interventions for a younger population, you're likely going to miss a huge number of people who also need treatment and services, who are not going to access services the same way as a younger population might. When looking at 2018 data, and 2018, this is from a CDC paper, looking at 2018 data using death rates, the opioid-related overdose death rate amongst non-Hispanic Blacks were the same or worse when compared to rates by total state population. So Maryland, like West Virginia, is one of the top 5 states with the highest opioid-related overdose death rates by total state and non-Hispanic Black population. And so that's not a place that we want to be in, but it is where we are. And Maryland also had the highest number of opioid-related overdose deaths among non-Hispanic Blacks and outpaced the second highest state, Illinois, by over 100 deaths. So we have a significant issue here that we need to have a targeted approach to address. We had all hoped that 2018 was going to be our peak in the current version of the opioid epidemic. However, as Steve already demonstrated, overdoses and overdose deaths in Maryland began to rise with an increase in 2020. However, these death rates actually began at the end of 2019. And that recent increase that we're seeing is also being impacted by race. So while overall fewer people went to local EDs in 2020, as we spoke about in the same time period from 2019 to 2020, the 2020 data indicates that between April and June, when people did start going back to the emergency departments, overdose trips related to the emergency room increased by 29% for Blacks, but 84% for African Americans. And looking at overdose deaths, Maryland had another banner year, unfortunately, for opioid overdoses in 2020, which was exacerbated in large part, as we've discussed, by the COVID pandemic and the challenges this has brought in the economy and personal suffering and in loneliness. Through the first 3 quarters of 2020, opioid-related deaths increased across all racial groups, as Steve mentioned. However, the rate of increase in deaths among African Americans and other non-white racial groups outpaced that of whites. And African American deaths increased by 33%, and deaths among other races have more than doubled compared to an 11% increase for whites. And this higher rate of death among non-Hispanic African Americans is largely driven by increased fatalities amongst older African American adults. Overall, intoxication deaths among African Americans from the ages of 46 to 55 increased by 47% during the first 3 quarters of 2020, while deaths among those over the age of 55 nearly doubled, exhibiting a 90% increase over the same time period a year ago. All drug use disorders are not the same. And even if the substances are the same in each individual, the response has to be tailored to the individual. And this opioid epidemic and the disparate responses to our sincere efforts to combat this problem has been a hard reminder that the differences of the communities need to be taken into consideration when designing community-based responses. We do have to look at access to substance use disorder treatment and insurance status, lack of access to other treatment options, looking at the fact that methadone is more available to white individuals than it is to Black individuals, making sure that we're confronting stigma and the issues that are associated with poverty, healthcare illiteracy, trauma backgrounds, educational attainment. All of these things need to be taken into special consideration when you're dealing with, well, when you're looking at any population in general, but certainly if you're looking at a minority population, these are things that you cannot be remiss to address in your interventions. And so therefore, looking at all of these numbers, knowing that nothing is going to get better if we don't do anything any differently, and knowing that we're all working so hard to face this and confront this problem, what I've asked, and I'm thankful for the acceptance by the Lieutenant Governor, was to develop a racial disparities task force that would promote more equitable health outcomes, investigating what's contributing to this increase in overdose deaths, and recommending solutions to eliminate the racial disparities related to overdose fatalities. If we can do this, which I believe that we can with the partners that we are looking to pull together, if we can do this, then we can be a leader in the nation in addressing this problem, because as I mentioned, Maryland's not the only state that has this issue, but nobody has solved this problem. So it would be great if we could be the state that could do that. So our goals of this task force would be to identify focused, data-informed interventions, policies, and programs that will reduce the disparity in overdose deaths, that have been escalating despite all of our best efforts, to recommend policies and programs that will decrease factors that contribute to the disparity in overdose deaths, that we could determine how to increase acceptance of evidence-based practices in affected communities using a targeted approach, and lastly, that we would ensure adequate allocation of resources to targeted communities. We need to increase our cultural sensitivity in the treatment of opioid use disorders to increase the uptake of treatment options. And we have to make sure that we're examining the effect of healthcare policies and clinical practices on Black people with substance use disorders, and look at how we're talking about opioid use disorders and how we're communicating about this treatment and the reframing of the treatment, because we can't ignore that if we really want there to be an honest dialogue and therefore a change in behavior. We can't ignore the changes that we've made and how it is that we're addressing drug addiction in the nation and the state included. So our goal is to have a collective impact, to create a multidisciplinary group from different sectors that would come together to form a common agenda to solve this specific adaptive problem. And an adaptive problem is a complex problem where the answer is not known, or there's no single entity that has all the resources or the authority to bring about the necessary change. This problem that we have right here, this disparity in opioid deaths, this is indeed an adaptive problem. It's complex. There are a myriad of confounding variables, and there is no one agency that can facilitate this change independently. We do have to work together. And so this task force would be made up not only of experts in medicine, but those in policy and finance, and also people who personally care about and are directly impacted and connected to this problem and the proposed solutions thereof. So people who have a true vested interest in solving this problem. And our deliverables would be to deliver a report to this council with recommendations on programs and policies that could be implemented to address the racial disparities in the overdose deaths in the state of Maryland after about after a year and a half of working together, listening and problem solving and coming up with some solutions. And that's my presentation. So I thank you. Thank you, Lieutenant Governor, for your leadership. Thank you for your support. Thank all of you for your interest. The state has a lot that it's trying to do with regards to opioid overdoses, as we all well know. If we don't get our hands and our arms around this problem with this escalating rate of opioid overdoses and African-American deaths, we are not going to be able to move forward in our efforts to overall drive down deaths from opioid overdoses. And this is impacting, it's going to impact many other interventions that the state is looking to do and to drive, and even in our healthcare financing system as well. So we really do have to get our arms around this.
Okay, thank you, Dr. Jones. And your co-chair, Dr. Brathwaite, is on this call as well?
Yes, he is.
Yeah.
And thank you for putting us together. It's going to be a wonderful team.
Yes, I'm
Good
here.
afternoon.
I'm here.
Good afternoon, sir. I'm glad that you could be a part of this.
Yes, it's my joy to be a part of the solution to the ecosystem problem.
Okay, thank you. Dr. Jones, two things in the presentation. The impact, or I should say the fact that older African-American population, in terms of looking at the demographics of the fatalities, what I have said for a while is, and it's probably not the best term to use, but I called it the traditional heroin users. That these are not the new heroin users that came off of prescription opioids. You know, people who are in their 50s and 60s. In many cases, now there may be some, but many they date back to, you know, my younger years and then I was going to ask the correlation with location. Because I've always related, and it kind of plays out in some of Steve's numbers. I grew up in Washington, D.C., and the Washington, D.C. and the Washington area, now back in the late 60s, early 70s, heroin was a big issue in D.C., but it kind of went down substantially, almost going away, but was there, but went down. Baltimore, it never went down. Baltimore stayed a heroin town. And so when the what I call then the new heroin users who went from prescription medications to heroin and now fentanyl came about, it just increased somewhat in Baltimore, but it mostly increased in other parts of the state. And you saw that Prince George's and Montgomery County, while they saw increases, it wasn't as sharp as Central Maryland, largely because Baltimore had, as I say, always been a heroin town. Probably goes back to when heroin was first made illegal, that it just was a heroin town for, before my time and currently. So I don't know if you've done an overlay of the age and location, because it just, based on my experience, I would think a large proportion of those older fatalities are Baltimore related, that there are a lot of the people in Baltimore or nearby former Baltimore residents.
So you have a very good understanding of this issue, Lieutenant Governor. So yes, Baltimore has historically had a problem with opioids, and that goes back 30, 40 years, as you well know. I also, and yes, the people who are dying from opioid overdoses in African American community are older, regardless of where it is that they're dying, whether they're dying in Baltimore City or not. And if you look at the overdose death rates in Baltimore City, they have escalated. So we had a problem before, and I say we because I practiced in Baltimore my entire career. So we had a problem before, and that problem has gotten dramatically worse with the addition of fentanyl on the market because it is so much more potent than heroin is. It's actually been the worst thing for the opioid epidemic in the state of Maryland, and also across the country, because this is the same thing that's happening across the country, is that overdose death rates are increasing because of the increased potency of fentanyl that's hitting other people's markets later than what it hit ours. And if you look at where the death rates for the opioid for African Americans are occurring in the state of Maryland, number one location is going to be Baltimore City, but then the other top three after that are Baltimore County, Anne Arundel County, and Prince George's County, with Prince George's County being the lowest amongst the four different jurisdictions. And so we would be looking through this task force to do a better job with on the ground, working with the communities that are most greatly impacted. And we have heat mapped it down even to the zip codes where where the hottest areas of opioid overdose deaths are occurring in those four counties. So looking at doing a better job fostering partnerships with communities, and not just with providers, but with those who can become champions and support the cause of, and helping us to combat stigma, and also addressing some of the other myriad social issues that are barriers to people either accessing care or staying in care.
Yeah. Well, you point out an interesting point that comes out of Steve's data is that, Prince George's County had a substantial increase in heroin overdoses, which is, a little different from what I was just saying about the trend. And the drugs of choice in the DC metro area were not necessarily heroin. It was more of PCP than it was the opioids. But
no, that's completely right, and that is true. And but even if you look at prior to 2020, the rate of overdose deaths in Prince George's County, it still was number 4, and that would just be because there's the sheer number of African Americans that live in Prince George's County, so you're going to have a concentration there. So, but yes, it's definitely still a PCP town. What happened in 2020 with the increases in overdoses in Prince George's County was a complete surprise to most of us. But the fortunate thing is that it looks like it's coming back down to historical numbers, which is great, which is what we would like to see. But even at historical numbers, it still would be number 4. And then also, if you look at in Prince George's County, the number of resources or the lack of resources that there are for the treatment of opioid use disorders, also supports the notion that we have to have that we need to look, at what it is that we can do to better engage that particular community to address the overall challenge that we're having with opioid overdose deaths in the state in the African American community.
Okay, thank you. Any additional questions for Dr. Jones or Dr. Braithwaite.
Yes, Lieutenant Governor, this is Glenn Fuson again. Sorry for all the questions, but
No, don't apologize.
Dr. Jones, yeah, very interesting presentation. Thank you very much. Are we seeing, and if I missed this nuance, please excuse me, are we seeing the same discrepancy in other drug overdoses, or is it just heroin that we're seeing that discrepancy for African Americans?
Oh, you mean like for cocaine and for alcohol,
Yeah,
things like that?
and I know the death rate is different and all that. I don't know how you would group it together. I guess what you made a great point, I think, and it's where I was going is, are the services there, period, for the African American community? And I guess I just wonder if we're seeing that same disparity in other drugs of choice.
I can't say that we've looked. Well, let me rephrase. We may have looked at the top of my mind. I don't have at the top of my mind if there's any difference in what that looks like in for other substances. I know that for cocaine is certainly going to be higher amongst African Americans. But if we're looking at deaths in general, the greatest number of intoxication deaths are related to opioids, and so you're going to have your greatest impact if you're going after where the most deaths are. And even if you look at deaths from other substances, usually in the state of Maryland, if you're dying from another substance, a huge majority of the time, I think 80% of the time or more, there's going to be an opioid in the presence of that as well. So you're going to address, you're only going to address opioids if you're looking at opioid treatments, treatment of opioid use disorder. However, you're going to address a population that has a tendency to use more than one substance if you're working with the opioid use disorder population, because you can't just work with one substance. You're gonna, if you're helping them with one, there's not a guarantee, but you're increasing the likelihood that you're going to be also helping them with the other substances that they might be using as well.
And I think that kind of gets to the point that I was going at is as you develop the community that you're looking at. I mean, even if we look at alcoholism, are we addressing the problem of alcoholism with disparity between races as well? And maybe are we looking at that? So I guess that's kind of the question: is the group going to look at disparities as whole or just in the opioid?
Well, I think that what we're looking at is we're trying to see why does one population behave differently from the other. And we're going to be looking at polysubstance use and seeing if there's a difference in polysubstance use between the different populations. I know that Steve recently asked my team for some information about that. And if we find that one of the differences is polysubstance use, then yes, we would have to do something about polysubstance use. But we're trying to get as much data as we can so that we can have as many data-driven interventions, because there's 20 million things that one could look at, but we really kind of want to see where we're going to get the most bang for our buck.
Well, thank you very much. If there's anything my office could do, please let us know.
I appreciate you.
Okay. All right. Thank you, Dr. Jones. If there are no more questions for Dr. Jones and Dr. Braithwaite, we'll go to Erin Russell from the Center for Harm Reduction and the Department of Health.
I'm sorry, can somebody take my share screen off, or do I have to do that? I don't want to mess.
Maybe I think you do.
I think you do. Right.
As we're looking at your calendar, it looks like mine.
At the top of your screen, that you might see something a little red that says "Stop sharing."
I'm trying. I'm really trying.
Yeah, Dr. Jones, you need to schedule some free time in there.
I'm really trying over here. I'm so sorry.
There we go.
Did you do it? Thank you. Sorry.
All right, and now you should be seeing my screen. Okay, good afternoon. I'm Erin Russell. I'm Chief of the Center for Harm Reduction Services at the Maryland Department of Health. Thank you, Lieutenant Governor and members of the Heroin and Opioid Coordinating Council. It's really a pleasure to be here appreciate it very much. Excited to share the data that we have to start to evaluate the impact of our naloxone distribution that the state of Maryland has done a tremendous job investing in. So I'll introduce the Center for Harm Reduction first, and then go into an overview of kind of naloxone distribution to date and what we're calling the saturation formula. So we are housed within the Prevention and Health Promotion Administration within Public Health Services at the Maryland Department of Health. The mission of the Prevention and Health Promotion Administration is to work with community-based partners, health departments, and other providers to particularly focus on at-risk and vulnerable populations. So we work alongside our colleagues in infectious disease who address hepatitis, HIV, sexually transmitted infections, and other infectious disease issues. So the Center for Harm Reduction kind of fits right in to look at a full spectrum of drug user health needs. Within the Center for Harm Reduction, our niche population is people who are in active drug use. So it's people who are using drugs in a variety of different ways. We know that there's people who are using occasionally or people who are experiencing an active addiction. They may or may not be engaged in treatment, and those are our people. So we believe that by optimizing services for people who are actively using, we will have an impact long-term on substance-related morbidity and mortality. And so we believe that will be achieved by creating healthcare and social service systems that meet the needs of people in a comprehensive and community-based manner. We bring a lot of our programs to the community, and we believe in integrating multiple services together. So naloxone is a great example of that, which we'll talk about. But incorporating naloxone into the emergency room for people to take home, emergency medical services doing leave behind at the scene of an overdose, but as well as incorporating HIV testing into a buprenorphine treatment program, or hepatitis C testing is incorporated into our syringe service programs. We try to meet the variety of needs that people who use drugs have in kind of a one-stop shop manner. And we try to achieve equitable access to those services across the state. And we do a lot of capacity building and training to address stigma and discrimination of people who are in active drug use. And so we are working to evaluate all of these programs, and the saturation model that I'll present is one way that we're evaluating our impact. We're actually partnering with the Johns Hopkins Bloomberg School of Public Health to look at the collective impact of the Center for Harm Reduction Services. If we believe, I'm hoping that by achieving comprehensive care and community-based care for this population, it'll also prove to be cost-effective and in the context of the opioid crisis and within our healthcare system at large. So that's a brief overview of the center. We were actually established in 2019. So we're coming up next week on our 2-year anniversary of existing, which is quite special because Maryland is only one of a handful of states in the country that has a state level office dedicated to this topic and dedicated to coordinating services related to harm reduction. So I celebrate those anniversaries because we're very proud of this work. So as I mentioned, Maryland has done an excellent job to get naloxone out, and we're also fortunate to manage what we call the Overdose Response Program, which I'm sure many of you are familiar with. The Overdose Response Program is managed by the center, and so we approve local programs to distribute naloxone out in the community outside of that patient-provider relationship. You can still get naloxone from your medical provider, get a prescription, and you can also walk into a pharmacy and get it kind of behind the counter from a pharmacist without a paper prescription. And that's a statewide standing order that's issued by Dr. Chan from the Maryland Department of Health. So we have over 150 overdose response programs, and we've worked very hard to expand that, particularly during COVID, bringing on new nonprofit organizations, new law enforcement agencies, all the health departments are approved programs. It's a wide range of organizations that are getting naloxone out. And one fortunate thing is that since we manage that program and there's a state law mandating it, all the data about training and naloxone distributions comes to us on a monthly basis. So that has helped to inform the model that I'm going to present. It's really only possible for us to do this because Maryland has a law set up to allow for this kind of tracking. Just is unique to Maryland. And we currently purchase all the naloxone that's available in the community in Maryland, with the exception of a pharmacy or medical provider. If you're an overdose response program, you can place an order for naloxone with us on our website, and it will ship it directly to you. And we've been fortunate with the state opioid response grant and our partnership with the Behavioral Health Administration to have enough funding to cover the demand for naloxone in the state. So if you know of anyone who needs naloxone, nobody should be wanting for naloxone in the state. We have the resources to provide it, and we've have the ability to get it out there. So the question I always get is how much naloxone do we need? Like how much naloxone needs to be out there to actually have an impact? And it's not inexpensive. I mean, it feels inexpensive, compared to the cost of an overdose and the, cost of life. But it's still a major investment that the state's making. And so how much is enough? Unfortunately, but fortunately, there's only one article that really speaks to this. And I'll put a link to this article. I've got a couple links to send out to you all once I close the presentation. But I'll send a link if you want to read this in full. It's from Scotland, and they focused on a population of people who are leaving prison and hospital settings. So they gave individuals leaving those controlled settings a naloxone take-home kit. And then they evaluated how many overdoses took place, and they came up with this model for how much naloxone was needed in the community to have an impact on overdose deaths. And they saw a 30% decrease in the risk of overdose death by, quote, saturating this community with 20 times the number of naloxone kits as overdose deaths the previous year. I'll walk you through that math in a moment. So what's really critical about this equation is that they looked at people who are at risk of overdose. That's was central to the effectiveness of their model. And that also comes into play when I show you how we're applying this model in Maryland. So it's not 9 to 20 times overdose deaths in a jurisdiction, naloxone in the hands of the general public or anyone. It has to be 9 to 20 times overdose deaths of naloxone in the hands of people who are at high risk of overdose. And so that's people who are actively using drugs, people who may be in medication-assisted treatment, and then we consider their friends and family and people who directly interact with them to be within that kind of high need, top priority group as well. And so again, this study defined saturation as between 9 and 20 times naloxone kits, 9 to 20 times overdose deaths in a jurisdiction, and then that would lead to 20 to 30% reduction in overdose-related deaths. So as I move forward in this, we are using this as a way to evaluate how we're doing with naloxone. Like I said, to answer that question of how much do we need out in the community to start to see an impact? Are we doing enough? Are we targeting our naloxone distribution enough to see an impact? And it's not meant to be punitive to the jurisdictions who aren't like, quote, meeting saturation, as you'll see. It's really just meant to help us guide them in thinking about how to prioritize and retarget their work. Also, this is a starting point for us. There's a lot more data work to be done, and hopefully we're bringing on an epidemiologist soon who can help us dig into it. But for now, this is helping us to just do a high-level evaluation, and we're looking at a jurisdiction level in order to see where we need to beef up our resources in each area. And so at that high level, we looked at within jurisdictions, if saturation was met for 1 quarter, so we're comparing 3-month periods from one calendar year to the next calendar year. So we'll look at the first quarter of 2019 compared to the first quarter of 2020, for example. When doing that, we've noticed that overdose deaths went down by an average of 3 deaths compared to a previous quarter in those jurisdictions. It was 1 death compared to the previous year's quarter, as I mentioned. But when looking at timeline, so 4th quarter of 2019 compared to 1st quarter of 2020, then we saw a more immediate impact of the saturation model. So we're trying to figure out, this is another area where we can explore more and play more with the data to see the impact over time. If saturation was not met in certain jurisdictions, then overdose deaths went up by an average of 2 deaths. Again, comparing a previous quarter to the next quarter, and then from the previous year to that next year's quarter, it was less than 1 death. I think it was about like 0.3 deaths. So that didn't really reveal too much. And so just to emphasize, I'll show you walk you through the calculations and show you the impact in Maryland on the next slide. We're looking at our data to understand how many naloxone kits are getting in the hands of people who have social experience using drugs or their friends and family members. So when we collect that data, I mentioned that we collect monthly reports from our over 150 plus programs in the state. They share how many people they trained, what their demographics are, and then what their reason for training was, as well as the setting and kind of some more context for where that training took place. And we pull from that if we consider the target population to be if social experience is indicated as the reason for training, or if they're family members. So this would not include people who are obtaining naloxone for their work or volunteer, or we have a separate category for law enforcement. I just want to say that's just to stay true to the model and the literature, but not to say that law enforcement and other providers are responding and reversing a huge amount of overdoses on a regular basis and having a huge impact as well. All right, so here's our calculation, and I'll walk through Anne Arundel. So Anne Arundel County had 218 overdose deaths in 2018. So to achieve saturation with the most conservative estimate, we're using 20 times those opioid overdose deaths. And so that means their target for distribution is 4,360 naloxone kits, again, to that target population. So when we pull data, we include, as I just described, the target population from the data that we collect. We will also align that with Medicaid claims for naloxone that's distributed at a pharmacy in that county. So within 2019, they distributed 4,523 kits. And so they surpassed their saturation target. And so we would consider them to have achieved saturation of our target population. And so this is our breakdown of how counties did in 2019. It's a big mix, as you can see. Our highest performing counties are Baltimore City, Cecil County, and Kent County. I know the Whitsitt Center has given out most of those kits on the Eastern Shore. We have a good relationship with them. And Cecil County, also the health department, along with Voices of Hope, they're a nonprofit organization in Cecil County that we work closely with. They've gotten a lot of naloxone out, particularly through their newly established syringe service program in 2019. And this has been shared with local health departments, with our community partners, and we just also note it's shown from a county level. So within each county, there might be multiple overdose response programs that are contributing to these total numbers of kits distributed. For example, Baltimore City, it's not just, it's the city health department, which gets a huge number of kits out. It's also Behavioral Health Systems Baltimore and Be More Power, and a number of other treatment programs and nonprofit organizations. So this doesn't call out any particular health department or agency. We're looking at a county level, again, to get that systems view of what's happening with naloxone access in this jurisdiction. So unfortunately, looking at 2020, this goes through Q2. No one is probably surprised that we have not achieved saturation yet, looking at half of 2020. We know that a number of programs had to shift resources, redirect in response to COVID. One of the links that I'll send you all, though, it links to our website, and you can view there a video describing how many of our programs adapted during COVID and continued to provide services and really, once I think people adjusted, they adjusted quickly and then got so much more naloxone out. We also strengthened our partnership with opioid treatment programs, thanks to the Behavioral Health Administration. And we've been purchasing and shipping naloxone to opioid treatment programs to get them naloxone to people whose methadone take-home kits have increased in dosage. So we're going to rerun these numbers, and I will be happy to share an updated chart now that we have Q3 overdose death data, and also just move, as we can finally look at 2020 as a whole, and see how many of our counties were able to bounce back after this initial, the initial COVID setback, and achieve saturation. But again, it's not meant to be punitive. It just kind of helps give us a goal and a target for everyone. And this, I know this is probably quite small on your screens. It was just to walk you through the kind of how we're measuring everything. I mentioned we take the estimated number of kits that are given to our target population. We combine that with Medicaid claims. We estimate the number of kits needed that have been distributed to at-risk individuals. We take the opioid overdose deaths, the count of deaths, and we do that by incident location, not by location of death, if you're familiar with the death data. And then we multiply that by 20 to get a conservative estimate of the number of kits to be distributed. And then we'll compare what the difference is and how close they are to their target. So we have, this is my closing slide. We have 6 goals, 6 strategic goals in the center. And like I mentioned, they're all focused on integrating care, coordinating care, and increasing the number of services that are available to people who use drugs in Maryland. This is our goal related to naloxone saturation. It was a pre-COVID goal. So we're going to carry forward into fiscal year 2022 to try to achieve saturation in every jurisdiction. And thank you for giving me the opportunity to share that with you. I look forward to your questions and to any suggestions for partnership for us, or where we should be looking, or other resources that we should bring into this conversation.
Well, thank you, Erin. You went through the saturation model with Anne Arundel County. In looking at it in hindsight, or I don't know if it's too early to do that, do you feel that the saturation in Anne Arundel County has had a positive impact based on the earlier analysis that you suggested, or the model?
Mm-hmm. Yes, and I feel it was kind of informally tested with COVID as well in counties that decreased their service availability, particularly Western Maryland, where they have fewer overdose response programs, fewer resources that are distributing harm reduction services like naloxone. Just having them decrease at all, they saw one of the most significant increases in overdose deaths. And Baltimore City, I've been shocked at how relatively small, their increase in overdose deaths has been compared to 2019. And I know in the city, especially, and Anne Arundel, they have not slowed down at all and have in fact expanded access to naloxone in a tremendous way. So yeah, I'm very optimistic for places like Baltimore City, and I think it shows that their increase has not been as dramatic compared to counties where services have slowed a bit more. At least access to naloxone has slowed.
Thank you. Any other questions for Erin? Okay.
Erin,
Oh, Glenn?
Sorry, I will keep it consistent, sir.
Yeah.
Erin, and I apologize if you mentioned this already. With the saturation, I would assume that it's very important to make sure that you're saturating the same areas in which the overdoses are occurring. Obviously, in one area of the county versus another one. And if I missed that, I apologize. Are you tracking that you're getting the naloxone into that community?
We don't get that granular. We're looking at a county level and then using this as a way to mobilize partners, mobilize our local partners and local groups. And many of them are using tools like ODMAP or have other, ways of tracking non-fatal overdose to identify spikes and then send teams out. And that just varies jurisdiction by jurisdiction. So we're not necessarily using this model to do that at a state level and get that granular. It's a mobilization tool,
Okay.
I'd say.
Yep.
Mm-hmm. Thank you.
Erin, I have a question with regards to the calculation used to determine saturation. Was that based upon heroin as the drug or fentanyl, or does it matter? We know that you can require more doses of naloxone if someone's overdosed with fentanyl versus heroin. So I'm just curious as where that played into this.
So the study looked at opioid overdose deaths. So we're using the opioid overdose death number from the Vital Statistics Administration and the opioid and the OOCC's reports. So however it's broken down for the state as indicated as an opioid overdose death. So that it would combine then heroin, prescription opioids, and fentanyl related deaths.
Okay. So are you finding that people are using more naloxone to reverse when people have fentanyl on board, more so than when people just had heroin on board, not that long ago?
Yes, more naloxone is needed to reverse a fentanyl overdose, but also for any multi-drug related overdose. And that's even pre-fentanyl. If someone had a combination of a lot of different substances, it might take more naloxone to revive them. But fentanyl has definitely changed that game. And we've communicated to our programs that they should be giving out at least 2 doses. I mean, 2 doses is the standard, but if people need more, if someone is going to need more, there's no limit to how much naloxone. It's a need-based service. And yes, we're advising people to keep as much as they can on hand.
Thank you.
Okay. Thank you. Any other questions for Erin? Okay, thank you. Any questions for the good of the order? As we're getting toward the end, any questions or concerns or anything you want to raise, points? And that's for anyone on the line? Okay, not hearing anything. I just want to make sure that I know I went around earlier in terms of those here, and I see Superintendent Jones is on. So thank you. I want to make sure that that's noted in the record. And with that, I guess this has been a good program. A lot of excellent presentations. Look forward to working with the Dr. Aliya and Dr. Braithwaite's work group and the results from that. The naloxone saturation formula is quite fascinating, and we'll be monitoring how that is progressing and the impact that it is having. And of course, it was a good presentation, a lot of data that Director Schuh was able to provide us. So I want to thank you all. I know we were running up against the governor's press conference on COVID, but this is something that, we need to show that we're continuing to work in this very important public health issue that started before COVID and likely will continue to run after COVID. And so we have not forgotten, even if it's not on the front pages any longer, that this is a major public health challenge for our state and our country. And we need to continue our diligence in addressing the challenge that is out there. So I want to thank everyone for participating, and we'll be meeting again in another quarter. And please keep up the good work. Thank you all.
Thank you.
Thank you.